Hi everybody, and welcome to our module on respiratory acid-base disorders. In the video on acid-base principles, I talk about the 4 different acid-base disorders, and in this video we're going to focus on the first two, respiratory alkalosis and respiratory acidosis. In a respiratory alkalosis, the pH will be high, so it will be above the normal range at greater than 7.42, and the PCO2 will be low. If you look at the Henderson-Hasselbalch equation on the screen here, what's happening in cases of respiratory alkalosis is the PCO2 is low. That's the primary abnormality. That will cause the pH to increase, and then the kidneys will respond by excreting more bicarb so that the serum bicarbonate level will fall as part of renal compensation. In reality, there's only one cause for respiratory alkalosis, and that's hyperventilation. Anytime patients hyperventilate, they will blow off carbon dioxide and the arterial CO2 content will fall, and this will lead to a respiratory alkalosis. Now, there are many reasons why patients can hyperventilate. Some of them I've shown on this list here, and the first 3 are the ones that you will most commonly see clinically. Patients who are in pain or patients who are anxious frequently hyperventilate, and if you check their blood gas, they will have a respiratory alkalosis. If you have a patient on a mechanical ventilator and the ventilatory rate is set too high, then that patient will develop a respiratory alkalosis. 2 more rare causes of respiratory alkalosis, but 2 that you should definitely know for your boards, are high altitude exposure and aspirin overdose, and we'll talk about this later. And remember, the alveolar ventilation is the tidal volume times the respiratory rate, and most patients who are hyperventilating have a high respiratory rate. A normal respiratory rate is 12 to 20, so in board questions when they describe a patient breathing at a rate of 22 or 25 or 30, that patient is hyperventilating. Okay, let's talk about how high altitude leads to a respiratory alkalosis. At high altitudes, there's a lower atmospheric pressure. So if you're living at sea level, the atmospheric pressure is 760 millimeters of mercury. If you climb to the top of Machu Picchu in South America, the atmospheric pressure is 560. What this means is the oxygen content of air at Machu Picchu is going to be lower, and therefore you're going to achieve a lower oxygen content inside the alveoli of your lungs. The alveolar O2 content at sea level is 100, but the alveolar O2 content in patients living at Machu Picchu is only 75. And because of this low oxygen content of air, there will be low oxygen content in the blood, and that will cause patients to hyperventilate. So at high altitude, hypoxia develops because of the low oxygen content in the atmosphere, and this causes the body to respond with hyperventilation. When patients hyperventilate, they blow off CO2, and the CO2 level in the body falls, and this leads to a respiratory alkalosis, including a rise in the pH. So if you look at this table on the slide, I've written 4 key elements of respiratory function and how they change at high altitude. The partial pressure of oxygen in the alveoli and in the arteries is going to decrease because of the lower atmospheric pressure, as we just talked about. That will cause the respiratory rate to increase. That will in turn cause the carbon dioxide level to fall. And when the carbon dioxide level falls, a respiratory alkalosis develops with a pH that is increased. Acclimatization is the process the body goes through after living at high altitude for a couple of days. And a very important element of acclimatization is the renal response. So after about a day or 2 at high altitude, the kidneys begin to excrete bicarbonate. This causes the serum bicarbonate level to fall, and that makes the pH begin to decrease, and therefore the pH will fall back towards normal and no longer be as elevated as it was initially. For this reason, patients who climb to high altitudes often take the drug acetazolamide. What acetazolamide does is it promotes renal bicarbonate excretion, and it helps to speed this process of acclimatization along, and this helps to prevent symptoms of high altitude sickness. Besides the renal response, red cells also respond to chronic hypoxemia at high altitude by synthesizing more of the molecule 2,3-bisphosphoglycerate or 2,3-BPG, and this helps to unload oxygen from hemoglobin more readily. So as a result, in patients who have been living at high altitude for at least a couple of days, they will have a low serum bicarbonate level as part of the renal response, and their red cells will be more efficient at unloading oxygen because of the production of 2,3-BPG. The final special cause of respiratory alkalosis we'll discuss is aspirin overdose. Aspirin overdose is a little bit confusing from an acid-base perspective because it causes 2 acid-base disorders. Shortly after patients overdose on aspirin, they will begin to hyperventilate. This is because salicylates like aspirin stimulate the medulla, and therefore the respiratory rate goes up. And so this is going to cause an initial respiratory alkalosis when a patient overdoses on aspirin. Several hours after ingesting a high quantity of aspirin, patients develop an anion gap metabolic acidosis. This happens because salicylates decrease the rate of lipolysis, so therefore there are more fatty acids around, and they also uncouple oxidative phosphorylation and inhibit the citric acid cycle. This causes biochemical intermediates like pyruvate, lactate, and keto acids to accumulate, and all of these things are acids, so therefore they're going to cause an anion gap metabolic acidosis. So in patients who have an aspirin overdose, the arterial pH is variable because these patients have a mixed disorder. They have both a respiratory alkalosis and a metabolic acidosis. So the pH could be acidic, alkalotic, or can even be normal in some cases. The PCO2 is always going to be low because these patients are hyperventilating, and the bicarbonate is usually going to be low because of the acidosis. The way you will be able to tell that there are two disorders present is by applying Winter's formula. I talk about Winter's formula in the video on acid-base principles, but Winter's formula can predict the expected carbon dioxide in a patient with an acidosis. And if you apply Winter's formula, the actual arterial CO2 will be lower than what's expected for compensation for a metabolic acidosis. So here's a sample case. The pH is 7.36, which is very slightly acidotic. The PCO2 is low at 20 and the bicarb is low at 11. Because the bicarb is low, you know this must be a metabolic acidosis. And then you can apply Winter's formula to predict the carbon dioxide level. Winter's formula says the predicted carbon dioxide level is 1.5 times the bicarb plus 8 plus or minus 2. And if you plug in the bicarb of 11, you get a predicted PCO2 of 25. And that means that the predicted PCO2 is higher than the actual PCO2 of 20. You have a lower PCO2 than what you expect. And whenever this happens, this means there's a concomitant respiratory alkalosis, and therefore this acid-base disorder is describing a patient with a mixed respiratory alkalosis and metabolic acidosis, and that's what's typical for patients with an aspirin overdose. The diagnosis of an aspirin overdose is made by measuring a serum salicylate level, and the treatment is to alkalinize the urine with sodium bicarbonate. The goal of treatment is to get the urine pH to be above 7.5, and the reason this is beneficial is because alkaline urine favors isonization of salicylates. When salicylates become ionized, they become negatively charged and they can't diffuse out of the urine, so they stay in the urine and they are excreted from the body more rapidly. Moving on, now let's talk about respiratory acidosis. So in respiratory acidosis, the pH will be below the normal range, less than 7.37, and the PCO2 will be elevated. Once again, let's look at the Henderson-Hasselbalch equation at the bottom of the screen. In a respiratory acidosis, the PCO2 is elevated. That's the primary abnormality. This causes the pH to fall, and in response, the kidneys begin to generate more bicarbonate, and therefore the plasma bicarbonate level will increase as part of renal compensation. Just like respiratory alkalosis is always caused by hyperventilation, respiratory acidosis is always caused by hypoventilation. Anytime a patient hypoventilates, the CO2 level will begin to rise, and that will lead to a respiratory acidosis. Some of the reasons why patients can hypoventilate are shown in this slide. First of all is if there's a decreased CNS respiratory drive that causes the respiratory rate to become low. Commonly this is caused by medications. Classic drugs that do this are opiates and barbiturates. Another reason patients can hypoventilate is if they have respiratory muscle diseases. There are a number of disorders that cause the respiratory muscles to function abnormally. These include Guillain-Barré syndrome, polio, multiple sclerosis, and ALS. Patients with any of these conditions, if the respiratory muscles are affected, will begin to hypoventilate, and that will lead to a respiratory acidosis. Another common cause of respiratory acidosis is impaired gas exchange. Patients who have lung diseases like pneumonia, pulmonary edema, ARDS, or COPD have an impairment in the ability to blow off CO2. If the impairment is severe, the patient will not be able to ventilate the lungs enough to maintain a normal CO2 level. Therefore, they will effectively be hypoventilating, and that will lead to a high CO2 level and a respiratory acidosis. Patients can also develop a respiratory acidosis if some of the airways are obstructed. For example, if a patient aspirates a foreign body or if a patient has obstructive sleep apnea. These patients are not going to ventilate the lungs normally, and therefore they won't blow off CO2 normally, and that can lead to respiratory acidosis. Let's talk about the renal compensation for respiratory acidosis. What the kidneys are going to do in the setting of respiratory acidosis is they're going to filter and secrete more protons so that more protons go out in the urine. In addition, the kidneys are going to reabsorb more bicarbonate and also generate more bicarbonate. The net result of all these processes is that the serum bicarbonate level is going to rise. This is going to cause a metabolic alkalosis to compensate for the respiratory acidosis. So if you look at the Henderson-Hasselbalch equation on the screen here, the problem we have in respiratory acidosis is that the PCO2 goes up, and that causes the pH to fall. What the kidneys will do is increase the amount of plasma bicarbonate. That will tend to raise the pH and counteract the fall in pH from the respiratory acidosis. The classic example of this is a patient with COPD. COPD is a chronic disorder, and these patients chronically increase their PCO2 level because they can't ventilate their lungs normally and blow off CO2 normally. As a result, they develop a chronic respiratory acidosis, and their kidneys respond by increasing the plasma bicarbonate. And in patients with COPD, they always have an increased plasma bicarbonate to compensate for the chronically elevated PCO2. The same thing can happen in other chronic respiratory disorders where patients chronically retain carbon dioxide. Just a quick note on acute hypercapnia. Hypercapnia is an elevation of the plasma CO2 level, and acute hypercapnia can affect the CNS system. Carbon dioxide is a major regulator of the central nervous system blood flow. So when the CO2 goes up, there's increased cerebral blood flow, and this raises the intracerebral pressure. If the increase in CO2 is mild to moderate, patients can complain of anxiety or headaches. On the other hand, if the rise in CO2 in acute hypercapnia is severe, patients can develop delirium and eventually coma. These effects on the brain are sometimes collectively called CO2 narcosis, and they're all central nervous system effects of high levels of carbon dioxide. I'll finish with this slide with a super high yield point that you always want to remember, especially when you're rounding in the ICU with pulmonary attendings. The carbon dioxide level in the bloodstream is always determined by the alveolar ventilation. What this means is anytime there's an elevated PaCO2, by definition you have hypoventilation. As we've discussed, it could be from drugs, it could be from neuromuscular disease, or it could be from lung disease. Remember, lung disease alone does not cause an elevated CO2 level. If patients can increase their ventilatory rate, then even though they may have lung disease, they will have a normal CO2. It's only those patients with lung disease who are unable to increase their ventilatory rate sufficiently that develop high CO2, and those patients are hypoventilating. Conversely, a low PaCO2 always indicates hyperventilation. As we've discussed, this could be from anxiety or pain, from high altitude, or from aspirin. But the bottom line here, and which you always want to remember, is that the CO2 level always tells you how effective a patient's ventilatory status is. And that concludes our module on respiratory acid-base disorders.